Welcome to Pulse&Pressors, where critical care gets crystal clear. Posterior MI remains one of the most commonly missed infarcts because the posterior wall is not directly visualized on the standard 12-lead ECG. Instead of producing ST elevation, posterior wall injury generates reciprocal ST depression in the anterior leads. Understanding this inversion of the usual STEMI pattern is the key to rapid recognition. Patients typically present with classic ischemic symptoms, but often describe discomfort in the back, epigastrium, or between the shoulder blades. Many are mislabeled as having reflux, gallbladder disease, or musculoskeletal pain. This makes the EKG even more crucial. The Hallmark EKG clue is ST depression in V1 to V3, but this must be interpreted with technical precision. The correct measurement point is the J point, not the slope or terminal portion of the ST segment. A subtle amount of depression may be meaningful, especially when clinical symptoms fit. Posterior infarcts are nuanced enough that major societies acknowledge sex and age-adjusted diagnostic thresholds. ST depression of 0.5 millimeters is sufficient to raise suspicion in all women and all men older than 35. Younger men require a full 1 millimeter of depression because of more robust baseline voltages. Tall R waves in V2 to V3 are another major clue. An R wave in the anterior leads is the mirror image of a posterior Q wave. When paired with upright T waves in V1 to V3, the pattern becomes almost pathognomonic. But because reciprocal patterns can be misinterpreted, confirming with posterior leads is essential. Posterior leads V7, V8, and V9 are placed along the posterior axillary, scapular, and paraspinal regions. Even 0.5 millimeters of ST elevation in these leads is diagnostic, with modern guideline exceptions allowing 1 millimeter thresholds only for men under 40. The typical culprit artery is the left circumflex, which is notoriously underrepresented on the ECG. A dominant RCA can also cause posterior infarction, and RV involvement should always be considered, particularly if hypotension or bradycardia is present. RV ischemia means nitrates and aggressive diuresis may precipitate profound hypotension. Preload becomes essential. Bedside ultrasound strengthens the diagnosis. Posterior wall motion abnormalities or basal infralateral hypokinesis strongly support infarction. Echo also identifies serious complications such as papillary muscle rupture, leading to acute mitral regurgitation, a catastrophic but time-sensitive emergency often first detected in the ICU. Management revolves around rapid reperfusion. Aspirin, P2Y12 inhibitors, and anticoagulation remain core therapy. Nitrates and opioids are adjuncts used with caution, especially in inferior or RV extension. Posterior STEMI carries significant hemodynamic risk. These patients often require vasopressors, careful titration of inotropes, and early reassessment for cardiogenic shock. If shock develops, mechanical circulatory support becomes life-saving. Intra-aortic balloon pump provides afterload reduction, Impella unloads the ventricle, and extracorporeal membrane oxygenation, or extracorporeal cardiopulmonary resuscitation, can serve as rescue strategies when conventional therapy fails. Coronary angiography confirms the diagnosis and provides definitive treatment. Cardiac MRI plays a complementary role, offering exceptional detail in infarct size and tissue characterization. CT coronary angiography is reserved for stable patients with diagnostic uncertainty. The overarching message is that posterior MI demands a high index of suspicion. Most are missed because clinicians search for ST elevation and fail to recognize its mirror image. Using precise J-point measurement, applying age and sex-specific criteria, and obtaining posterior leads transform diagnostic accuracy. When identified early, posterior MI responds excellently to PCI, dramatically reducing mortality and preventing the mechanical complications that define late recognized infarction.